Now that we've talked about liver function, I want to discuss some of the liver function tests, some of the laboratory values that you can order to assess whether the liver is functioning well or not. And I've broken this down into a few different sections. So the first one we're going to talk about is our aminotransferases, ALT and AST. So these aminotransferases are enzymes that are found in very high quantities in hepatocytes. And because of that, if there's any damage to the hepatocytes, you will often see increased levels of ALT and AST. I put this chart here to differentiate the differences between ALT and AST. So ALT is an enzyme that often exists in the cytoplasm, whereas AST exists more so in the mitochondria. And why this matters is that if we think about a very common mitochondrial toxin, alcohol, that's going to affect AST levels more than ALT levels because it's in a higher concentration in this region. So in alcoholic liver injury, both AST and ALT are elevated because there's still damage to liver cells diffusely, but because the alcohol is more mitochondrial in nature, you're going to have a higher proportion of AST that is released, and you're going to see an AST to ALT ratio classically above 2 to 1. And the mnemonic that you'll see in a lot of your resources is this toast to alcohol, and that's to remind you that the AST is greater than 2 to 1 to ALT. And when we talk about the organs that have these enzymes, it's true that both of these enzymes exist in hepatocytes. And in the case of ALT, for testing purposes, you should assume ALT is exclusively formed in the liver. And so you can remember the ALT, the L in ALT will remind you that this enzyme is only found in the liver. On the other hand, AST has a very strong association with the liver. Don't get me wrong, but you can find AST in other tissues like the heart or muscle tissue. And we'll find out why this is relevant. So when we talk about these predominant conditions, and if ALT is ever increased, you want to think about anything that can damage the liver. So a lot of causes that have hepatitis will increase your ALT. AST, I want you to think about, you can obviously think about the hepatitis. All the liver causes can cause both of these. But if you notice an AST that's rising much greater than the ALT, I first want you to think about alcoholic liver disease, like we just discussed, if you ever see that greater than 2 to 1 ratio. But they might even throw you a trick question where they give you another cause where somebody's coming in, and let's say an older lady is coming in after being found down for several hours, and her potassium's elevated and her AST is extremely high. They have an elevated CK level. They might ask you, what's going on? Why is their AST elevated? And one of the answers might be they suffered liver injury, but the real answer would probably be they actually suffered muscle tissue damage. They might be undergoing something like rhabdomyolysis, where their muscle tissue is actually dying, and that's what's causing this isolated AST increase. So just keep those in mind. But that's a little bit more less likely to be tested. That they love this AST association with alcoholic liver disease, though. So now that we've talked about the aminotransferases, I want to talk about our favorite cholestatic labs, our favorite obstructive labs that we've gone through so many times now in the pancreas and the gallbladder section. So, phos, GGT, direct bilirubin, they're all going to be elevated in obstructive diseases. And we went over each of these in our hepatobiliary section in great detail. So as we know, bile is created in the liver, and bile contains all of these other components to it. And all these components can ultimately drain into our gut. And if there's an obstruction, these can all leak out into our bloodstream, and we'll detect it as elevated phos, GGT, and C-bili. Just a reminder, again, that conjugated bilirubin is elevated in this case, this obstructed case, I just always want to remind you when unconjugated bilirubin would be elevated. And the two things you have to remember are hemolysis. So remember that unconjugated bilirubin is formed from the breakdown of RBCs. And if we're losing a ton of RBCs, what's going to happen is that you'll have a ton of RBCs, a ton of unconjugated bilirubin. You'll have sorry about the slide there. You'll have a ton of unconjugated bilirubin present and detected in your blood studies. Liver pathologies can sometimes cause an unconjugated bilirubin, and that's because, as we talked about earlier, UGT is the enzyme that helps out to make unconjugated bilirubin more soluble. But if your liver's not working as well, you can have a little bit of a backup and you can detect more unconjugated bilirubin. Alk phos, just as a reminder, it doesn't just exist in the liver, it also exists in the bones and kidneys. So there we just showed you that alk phos can be elevated in obstruction, no doubt, but it can also be elevated if you have some sort of bone or renal pathology. That can cause a lot of alk phos too. So if you see alk phos, don't immediately assume liver. It's good to put that on your differential, but it could also be these other two organs. Where, on the other hand, GGT is pretty much associated with liver obstruction. So GGT, if there's an obstruction, you'll get a ton of it in your blood. And this time, if you do have a bone problem, you're not going to have elevated GGT. So it's much more specific. So now we talked a little bit about this already, but I just wanted to break down what a hepatocellular pattern looks like versus a cholestatic pattern. So a hepatocellular pattern, it just means it's a pattern that you'll see on labs when the damage done is directly to the liver cells, okay? And as we saw before, ALT and AST are enzymes that exist within those liver cells. So if there's damage directly to them, it shouldn't come as a surprise that AST and ALT will both be very elevated in some sort of hepatocellular pattern. On the other hand, because there's no obstruction necessarily, the alk phos, the GGT, and the bilirubin, even if there is some liver damage, usually most of those compounds can still escape through the bile ducts and flow through the GI tract, and you won't have significantly elevated levels. That's not always true. What you'll often see is these still will have mild elevations. It's not like they're just completely normal. There's still some elevation. But in a hepatocellular pattern where there's damage directly to hepatocytes, you're really going to see ALT and AST be elevated more than anything. What if we see an obstructive or cholestatic pattern? So this is happening because of the damage outside of the liver, but more to damage to the bile ducts or some other obstruction going on. And what's happening here, as we just saw, is that our favorite alk phos, GGT, conjugated bilirubin, those are all elevated because they leak out into the bloodstream. They have nowhere to go. On the other hand, because the damage really isn't directly related to the liver, the ALT and AST will either be normal or just a little bit elevated. So you can see, depending on whether the aminotransferases or the obstructive liver function tests are more elevated, it can give you an idea of where the damage might actually be arising from, the liver or the bile ducts. Now let's talk about this isn't as high yield, this urine bilirubin and urobilinogen, but I wanted to be complete. So if you have time to look at this and you really want to understand LFTs in its entirety, feel free to listen. Otherwise, even for step 1 or level 1, this is probably low yield, but I wanted to mention it anyways. Urine bilirubin, what that does is it detects the amount of conjugated bilirubin in the blood. This should also make some sense. The unconjugated bilirubin doesn't make it to your urine, right? It gets kicked out by your kidneys. So it's only going to detect the amount of conjugated bilirubin in your blood. And the conditions in which you'll see urine bilirubin, you can see it in liver disease and biliary obstruction. And so let's talk about each of these conditions right now and why they would increase your urine bilirubin. In liver disease, I've talked to you many times about how you can have unconjugated hyperbilirubinemia because nothing's getting metabolized and changed into conjugated. So here's our normal pathway. We have unconjugated bilirubin. It goes to the liver. It can get conjugated. And I've told you before, oh yeah, if you don't have a good liver, then you'll get a backup of these guys here and you'll get an unconjugated bilirubin. Now, I didn't lie to you, but I didn't tell you the whole story. So yes, that can absolutely happen where you just get liver disease causing an unconjugated hyperbilirubinemia. However, there's sometimes you have liver damage where your liver can still conjugate some of the conjugated bilirubin, but then you have so much other damage that it can't really get out of the bile ducts. And so in these cases, this can leak back out and you'll get a conjugated hyperbilirubinemia. And of course, this conjugated bilirubin can go to the kidneys and get excreted in the urine, and you'll be able to test that through the urine bilirubin. Obstruction, we've already seen this before. If you have an obstruction here in the in the bile ducts, that conjugated bili will leak out along with a number of other things that we've mentioned. And of course, this can be detected in the urine as well. Urine urobilinogen is probably the lowest yield lab finding you'll ever see in your life, but sometimes on tests they're going to give you urine urobilinogen. So I want you to know what that means. All I want you to know is that urine urobilinogen is an indirect measure of how much bilirubin actually makes it into your intestines, like into your GI tract. If you can remember that, then these questions will be so easy for you. So it's going to be elevated in any condition where a lot of bilirubin is making it into your GI tract. So a common one that they'll want you to know about is hemolysis. You have so much breakdown of unconjugated bilirubin into your liver, and your liver's trying to work as fast as it can. It's conjugating all this bilirubin, and a lot of that will make it into your GI tract. And I'll go over that in a second. Where would it be negative? What conditions can you think of where bilirubin just doesn't make it into the intestines at all? Well, it should make sense that biliary obstruction would be a very common contributor to a negative urine urobilinogen level. So let's go over urine urobilinogen briefly. So the first thing that's going to happen is that conjugated bilirubin is going to make it into the GI tract. So it's in our bile and it successfully makes it into our gut. What's going to happen there is that intestinal bacteria will start to do its work on conjugated bilirubin. So it'll actually deconjugate it back to the unconjugated form. And from there, it can convert unconjugated bilirubin into urobilinogen. So now we have urobilinogen in our GI tract. Remember, we're testing the urine though, so something else has to happen here, right? So urine bilinogen has two pathways. The first pathway is that urobilinogen can be converted into a compound called stercobilin, and this is excreted in the feces. And actually, this is what gives stool its brown pigment. The second pathway that can happen is that urobilinogen can actually be reabsorbed into our body, and then this can be excreted in the urine. And this is what gives our urine our yellow pigment. So let's discuss why urine urobilinogen would be elevated in hemolysis and pretty much negative or very low in obstruction. So in hemolysis, you have a ton of unconjugated bilirubin. And if you measured the blood levels of this patient would have an unconjugated hyperbilirubinemia. But it's not like your liver's not working. Your liver's seeing all of this unconjugated bilirubin, and it's working as hard as it can. It's probably overworked, but it's doing the best it can at trying to conjugate some of those compounds, and it's trying to get rid of them too. So it's throwing all that bilirubin into your GI tract. And if you have all this bilirubin in your GI tract, some portion of it will end up be converted into urobilinogen and into your bloodstream, and subsequently into the urine, creating a high level of urine urobilinogen in hemolysis. If we look at biliary obstruction, on the other hand, if we have an obstruction here, we're not getting any of the conjugated bilirubin into our intestines in the first place. So if you don't have anything coming in the first place, you can't go through that pathway we just discussed to ultimately lead to urine urobilinogen. The last section of liver function tests I want to group together are our synthetic liver function tests. So albumin, PT-INR, and platelets. This can give us some rough idea of how well the liver is working. And let's go over this. So albumin is a pretty good indicator of hepatic protein production. Remember, we talked about albumin right here as one of the most important proteins that is produced by the liver. And it should make some sense that if your liver is not functioning as well, if you have some sort of dysfunction, then your albumin levels will decrease. PT-INR is a measure of our coagulation factors in our liver. So remember here that our liver is responsible for several coagulation factors, 2, 7, 9, 10, and then protein C and S. And when our coagulation factors start to decline, our PT-INR levels will rise. And just as it does in liver disease. And I talk about this later on when we talk about cirrhosis, but just as a heads up, PT-INR, especially INR, is our most, how do I say this? It's the most reliable indicator of liver dysfunction, even more so than albumin. It's more accurate. And if you have acute liver injury, which can happen, because factor 7 is injured most on this. Let me go back to this. Because factor 7 is the quickest, it has the shortest half-life. If your liver's not working and you're not producing any factor 7, then your extrinsic pathway will be damaged, and that'll cause an elevated PT-INR. That'll be the first thing you can notice on laboratory findings to assess for synthetic liver dysfunction. And so let me move on to platelets now. So platelets, remember, part of the platelet process is that you need that thrombopoietin signal from either the liver or the kidneys for your immature megakaryocytes to start to mature and differentiate. And we have it right here that if you, oh, that's all I show right now. I talk about all this stuff later. Sorry about that. But all you need to know here is that this TPO is really important for maturation and ultimately platelet production. So it should make sense that if you don't have any TPO, then you might have thrombocytopenia. And that's why the platelet count decreases in liver disease. There's multiple pathways, but by which you get thrombocytopenia in liver disease. Just a heads up, it's not just this. Like for instance, we'll talk about portal hypertension later. If you have a bunch of fluid stuck in your portal system, a lot of that can back up into your spleen, and then your spleen can just basically eat up all your platelets or just kind of keep them sequestered in your spleen. So then you get that's another reason for thrombocytopenia. So don't take this as the only reason, but what I want you to know on this slide for now, I'm kind of rambling. I just want you to know that albumin, PT-INR, and platelets are all lab tests that are useful for you to determine whether your liver is working well or whether it might be a little dysfunctional. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.